Yeah? So you must be very tired, I think. Okay. So what I'm going to do is I think we are not going to take any questions. So tomorrow, we have slight change of program. I'm going to actually cut down my presentation for the WHO only for about 10 minutes. And then we have a whole session where you can ask any question on infection control. And so whatever question you have from today's session, you write it down. Because it's just because we are running late and you are getting tired, you know what I mean. I'm okay, but I'm just thinking about you. So care bundle approach, I think it's a very boring subject. So this is the challenge I face. I know what I have to do, but the challenge task is how to make the whole thing interesting. This is a similar dilemma which was facing by Jaja Gabur's husband, 8th husband, on his wedding night. Okay, so I'll make every effort to actually make it interesting, okay? But this is not my quotation, so don't quote me on that. Okay, so let's actually give a little bit of history about the bundle. So initially what actually happened that Institute of Health, IHI, started this 3-4 key intervention. Nothing to do with HCI at all. And they actually said 100,000 lives. And then suddenly they say, okay, we are now going to be very ambitious. We really want to save 5 million lives by introducing what we call bundles. Yeah? So that was the concept. And that's the concept introduced in terms of putting the bundles of the HCI, which was basically 4 at that particular moment of time. So why bundles are actually successful, and there's a lot of debate, are they successful, are they not, and you will make up your mind at the end because I'm going to show you some evidence on the both sides. And we were the first hospital in the UK to introduce the bundle, which I'm going to show you some of the data to see it does actually work if you do it properly. So first, I think there are too many national guidelines on the same topic. Now, as I'm looking at the website, you actually tell me, if you're talking of evidence-based medicine, why we have 14 international guidelines on putting the central line. Are you confused? I'm confused, definitely. The clinicians are confused, isn't it? Second question you want to ask you, which element of those guidelines, okay, are actually relevant? Okay, so the bottom line says, you say, can you cut the crap and give me the bottom line? Okay, so my book is all about that. I'm just giving you advice, don't do this and don't do that, and that's all, that's what it is. Okay, so don't give me all this literature, you know, I don't have time to read it. So that was the first thing. Second thing, I think, what actually happened, we failed. That there was too much emphasis on data collection, do surveillance, and do surveillance, and do surveillance, the CDC, okay? Do surveillance. And then surveillance reduce HCI. What evidence we have the surveillance reduce HCI? Zero. Okay? So public health actually collect all the data and say your infection rate is 5%. And then you as a surgeon go back and say, actually, can you tell me how do I reduce it? Well, I don't know. Because the data actually are fed within 6 months or 8 months' time. So surveillance is very important, isn't it? To actually find out what the problems are. But if you can't tackle the thing, what's the point of actually doing the surveillance if you're not going to reduce it? Okay, so I've got a very clear guideline on this one. So there's too much, and I think where we failed, where the bundle have been successful, is that too much emphasis on the outcome surveillance. So just collect the number and set the parameter. Okay, now you actually tell me when you're sitting in an aeroplane, will they give you a list? So now CLABSI is 3.3 per 10,000 bed. Okay, then those are the NIS criteria. Now, would you actually sit in an aeroplane? Would they give you a checklist to actually say that the X airline have got 13 crashes and this has got 13 crashes, league table? No. This is what the CDC does. CDC actually does list of the criteria that these are the one and this is the where you should keep your parameter. Okay, this is what we have been doing it. Airline doesn't do that because if it will tell you one crash, you don't want to sit in an airline, isn't it? So that's the problem. So I think there was too much. So what actually bundle actually did, they look at the processes. So what are the 5 things important? Remember I talked about the SAS survey we picked only 6 interventions in Africa, right? Introduced it and we see 60% reduction. Okay, we have to start somewhere. Can you do 100% or better? Yes, you can, and I'll show you the data. Okay, so I think counting infection, but not actually controlling it, which is this part. Now, if you control the process, you control the outcome. So airline industry, when you sit over there, they have a checklist, okay? So they say tire pressure is okay, and the wipers are actually working, and the engine pressure is okay, and the blah, blah, the whole lot. Aeroplane does not fly unless the checklist is complete, right? It does not fly. If there's any fault in the aeroplane, in that particular one, and they cannot mend it, it takes only 30 minutes for that information to be communicated on the Boeing 707 model all over the world. Within 30 minutes, you know that? And all planes are completely grounded, unless you sort that problem out. Look over here, this bolt is actually, we are having problem with that particular bolt, what we found out, air will be grounded. But 30 minutes, would you imagine? We don't do it, if you've got an infection in your hospital, you don't tell me, look over here, this is, no, but that's how they work, number one. Second issue, I think, about the compliance. So when they check the pressure, right? So when they tick the boxes are actually correct. So say, for example, if I'm actually putting central line on her, I may not wash my hand, and I tick the boxes. Pilot doesn't do that. Why? Because if they actually tick the boxes, they die as well. Okay? Because they know that if they actually say these are all okay, they will die as well. So this is what we call skin in the game. Have you seen this Talib's book called Skin in the Game? Read it, it's a fascinating book. That you will not going to do anything unless you got a skin in that particular game. Okay? So they don't have skin in the game. So I actually believe that if you control the process, you control the outcome. Okay? Classical example in the airline industry cannot be applied to healthcare setting partially because of this issue. And the third thing, I think, there are so many guidelines. You read this and you read that, and then second thing, they are not actually applicable to your own country. You can't actually find chlorhexidine, for example, not available in a lot part of the world. You know what I mean? So you take the CDC guideline, but it's not applicable. India has to actually have their own bits, depending on the cultural issue, the way you think, the availability, cost, and all these issues. So there's lack of consistency on the important element. So basically, bundle, if I summarize it, is group of practices when you put together. That is actually called bundle. That's what it is, as simple as that. All the element of bundle evidence-based? No. Okay? So remember that. All of them, they're not. Remember, I've shown you. I'm going to show you in a minute. So element, it's between 4 to 6. Don't go beyond 6. Less than 4, I think they're not optimal. On top of that, you can do something additional. Second thing you have to remember about the bundle, it actually takes lots of assumption. It takes assumption that you are using sterile equipment, you know about this and you know about that sort of thing. So it takes a lot of assumption. So when you have those things in place in the first place, then you implement that, then it's going to work, okay? So just be mindful of that, because in 6, there will be additional aspect. And I'll show you in a minute in my experience. So you pick 6 evidence-based measure. Some of them, they are not really evidence. Some of them, they are what we expert opinion, good practice. Why? Because we do not have randomized control trial because of ethical reason, okay? So I think the problem, there's a variation in practice. 4 surgeons, 4 ICU physicians are actually putting central line in a 5 way. And everybody want to have their own pack, and everyone to have their favorite antiseptics, yeah? So what actually happened that if you actually take this variation out, so here you have a problem. So there are 4 people are actually doing 4 different things, okay? 4 different interventions. So the outcome data, the surveillance you are doing is completely useless, yeah? You have got more surgical infection rate, he has got less, and I've got even more. I have to actually go into practice. So when you're comparing it, they're not comparable because the practice is not comparable, yeah? And this is the reason when you look at the data, like New England or whatever it is, when I review the paper, I look if these interventions are consistent or not. If there's a change of team, we just reject the paper, okay? And in terms of ground of quality. And this is the reason when you look at the Lancet and the New England, right, when we review the paper, the criteria are so strict that to get the publish over there, it will be very difficult, okay? So these are the criteria you use. So they should be. Now, if you have a single bundle, which everybody is doing consistently, then you know that everybody is doing the same thing, and the outcome you expect will be exactly identical. So the data of surveillance are actually much more meaningful. So when you're looking at the surveillance, which you have a session, just keep that in mind about variation in practice, okay? So I think, yeah, so advantage of sterilization, clinicians don't like it. You know why? clinicians don't like this bundle because they actually think this is like a cookbook. So if I want to make idli, dosa, or sambar, whatever it is, this is the recipe, okay, I have to follow. And they don't like it. No, I want to have my own way, kind of thing. So they actually say, this is just like cookbook medicine. You're telling me to do these kind of things, and I do not have a clinical freedom. So clinicians don't like it, okay? So they're independent-minding people. In some countries, there are more than the other. And if you go to Hofstede, there's a book I would recommend. Read it about the cultural differences, and you can go to website and put Hofstede, compare India with Norway and all this country, and it's absolutely fascinating, okay? So we'll talk. If I've got time, I'll show you a couple of slides tomorrow. There's actually rest potential or error, reliable outcome, good stock control, very important, yeah, because sometimes things are not available, isn't it? But if everybody's using the same thing, then you don't have a problem. Cost effective and make patients safer. So can you see these are the advantages of actually putting the bundle? So what actually happened that these 4 surgical sites, these are the 4 bundles which we are going to talk about to see what element. And the slide which I'm going to show you, they're all in my new book. So, okay, I'm not here to sell this book, but I'm telling you all the stuff is there. And each one, I've taken each one out and given the scientific information behind the whole thing with references, okay? So don't worry about all the stuff is there, you know. So what I've told today, tomorrow, and now would be all in my book, everything, the whole thing, risk man, the whole thing, stuff is there. So it's surgical set, all these. So let's actually, so IHI actually published these guidelines in 2011. First guideline was published in 2007. Okay, 2006, 2007. So these are the bundles. There are more MRSA and hand age and things like that. But can you see CLABSI, SSI? There are 2 on SSI, the orthopedic and the surgical side, VAP. Coming back to the pediatric, I think one pediatrician was there. Can you see there is separate for pediatric infection because they are complex, okay? So just make sure that they're all adult. So don't apply on pediatrics. The following year, 2007, United Kingdom have developed their own, we don't call them bundle, we call high impact intervention, okay? Because most of the world, the infection control expert, hate absolutely the name bundle. Do you know that? Okay, we could argue we don't want to use the bundle. And I don't want to go because I don't have time, okay? So there's politics behind this name as well. Okay, so NHS Saving Life 2007, high impact intervention bundle. I like this one compared to the other one because all the other elements over there, they consist only of 4. Some of them are not really evidence-based, some of them have nothing to do with infection control, like control of DVT for central line, something like that, you know what I mean, okay? So, Saving Life, this has got beauty. So they published the bundle like intervention 1, 2, 3, 4, 5, 6, 7, okay? This has got beauty. So say, for example, if you are inserting device, then there's insertion bundle, yeah? These are the things you do when you're inserting the line. And this is what you do when you're maintaining it. Make much sense. IHI doesn't do that. They 4 element, each of them 4 or 5, and that's all they do it. Okay? So I don't think so they're effective, okay, in my view. And then people have actually changed it and taught it, whatever it is. So now, this is the document published, updated in 2017. If you go to the website, you will get the April issue, which is not the updated one. This one, you can't get it unless you're a member of the IPS. So what I'm going to do, I'm going to email Dr. Shastri this copy, and he can email you all of them. Because some of the document I'm going to do, I think you can actually make USB and give it to you. This you will not get on the internet. Okay, but I want you to read it because the 2004 is April 2007, and after 5 years they've changed it, you know, because some work we were doing at the WHO which have changed the evidence because of the publication of good quality paper, yeah, okay? So what I'm saying you, even 2 years' time, I will be saying something different because this is the evidence we have at this particular moment of time. And they talk about all this, but they talk about the antimicrobial stewardship bundle and also chronic wound are additionally added to this one. So I think surgical side, I'm not going to go through it, but if you look at the one, shower, shaving, antibiotic, decontamination of hand. So this is pre-operative. Intraoperative, clean item, clean environment, alcoholic hand rub solution, limit number of people, and maintain hypothermia. Now, if you look at out of this one, 4 of them, according to WHO, have got good quality evidence, yeah? Strong recommendations. 1 is conditional, 2 are not included. Okay? Okay, so the ones which are not included really limit the number of people, yeah? But remember, we included in the SAS project, in the African project, because that was a major issue. But because we could not find any paper, but logic and scientifically we're thinking that's the right thing to do. And when we did that, we actually seen the improvement. And also the element of asepsis, sterile equipment, that wasn't there, okay? Because we could not actually find any evidence, because nobody will actually admit that they were actually operating on the patient or putting the line, yeah, with the dirty instrument, no. But it happens, okay? So we will not find any evidence on that as well. So these are the elements, okay? So I'm going to show you about the biofilm, because this is very important. We are now going to talk about the device-related infection. I'm going to show you about the video, in which I'm going to show you about the biofilm and the quorum sensing, and then I'm going to show you the video in terms of insertion, when you don't clean the thing, what actually happens, okay? So these visual aids are something are more effective. They're all about 30 seconds video. I'm going to start playing. Okay. So what happened? The bacteria comes in. You read this pin around here, and they keep putting things together. Now, this is what we call quorum sensing. How many people have heard about quorum sensing? Excellent. Okay, so this is going to talk about quorum sensing. So this is the quorum sensing. These bacteria, they do talk. They don't have tongue, but they have chemicals. Okay, they talk through chemicals. So they are now talking to each other, right? And then now they're actually producing the extra cellular fibrin for attachment. Now they're coming near. So read this bit here. And there is polysaccharides all between. And can you see all this slime is now produced? So bacteria, they're all embedded in this particular slime, yeah? Okay? Now they're talking to each other. And people who don't know about quorum sensing, I'm going to explain what it is, okay? You want me to explain quorum sensing, what it is? Oh, you all know. So here cells from the upper cell, they just dislodge because it's just a clot formation. And then they actually go into the blood or urine, yeah, any device. Okay, so that's really quorum sensing. So bacteria comes over, attached, talk to each other through chemicals, that how many they are, okay? And then, now the quorum sensing is actually very important viruses as well, right? It's only important viruses because they go over into your liver and spleen and they multiply and they say, now this is the right number, attack now. That's why we have got the incubation period. When they attack, you get fever and you're actually very ill, okay? But they are very clever. They want to make you ill, but they don't want you to die. Why? If they die, you die as well. They want to spread. They want you to cough when you sneeze and have diarrhea, okay? So they can spread and they can survive, okay? That's the reason. So I'm going to show you 3 clips, which is only about 30 seconds. What actually happened, green are a bacteria. What actually happened when you put in dwelling devices, the IV line, how the biofilm form, how they are mature and how they are dispersed, okay? And then we talk about the device, any device, NG tube, nasogastric tube, any tube, okay? So this is the first one. So you see, this is the catheter which is inserted, and these greens are all bacteria on the skin. So what actually happens when you're inserting the catheter on a skin, if the skin is not disinfected, then it actually not goes from into the outside, but also the inside, right? So what message I'm trying to convey? The disinfection of the skin is very important. You will not sterilize the skin even you put your hand into autoclave, okay? That's the only way you can sterilize your skin. So you're not going to do that, okay? So you keep on cleaning it till you reduce the bioload, by 3 to 4 log reduction, okay? And the one bacteria which are bad are the one which are transient bacteria, not the resident one. Those are difficult to clean, okay? So this is the one. So now it goes in. Can you see it has taken all the green bacteria? So the first message, cleaning of the skin is absolutely critical. No matter what you do, they will carry some bacteria. The question is, do you want to carry them less bacteria? So let us see what actually happened. Now the catheter is inserted, okay? So now remember the bacteria is inserted. I don't know what's happening with it. Yeah, it's here. Yeah. Okay, got it. So now the bacteria are inserted. Can you see all the green are coming out? So all the fibrin is all collected. The blood is all collected, the white cell. And then the film is now mature. And the bacteria, they are dispersed. This is the time when you get bacteremia. So the message we are trying to convey is first you thoroughly clean the skin. No matter what you're going to do, the biofilm is going to form. When it's going to mature, then it's going to cause bacteremia, and this is the reason that you have bacteremia in the blood. Now, if this actually depends on certain factors. First, the type of the material you are using. So silicone is really state of the art, the best material, because the biofilm formation attachment is much less in the silicone. So it depends on that material. Second thing is also depend on the days you keep it in. So first, what you're going to do, don't insert it if you don't need it. Review it daily. Take it out. Take it out as soon as possible. And that's really the bundle, finished, of all CVC. I'm going to go through it, but that's what it is. So can you see the visual effect, of this thing, what's actually happening? Second thing, if you keep it longer, and pull your catheter out, sometimes the patient will actually get bacteremia. Why? Because can you see all this bit which is lodged at the end? The tip is just going to actually blow the whole thing. And sometimes what happens in catheter, if you keep it long and pull it out, you must have seen patient bacteremia. I've seen it, you have seen it as well. Same thing with the line as well. So therefore, the removal of line, remember the 7 days, bits and pieces, and it's not 5 days. It's because it's a maturity. If you leave it longer, you pull it, the patient will have bacteremia. Because it's mature, the number of bacteria are higher. That's the all bundle talks about, okay? It's complete common sense. So I'm going to go through these slides. So I think it's just the visual sometimes things are actually much more important. Okay, so I think this is not, so remember, this is really summary. I just want to cut down the time because I want to convey the message. Okay, so I think avoid unnecessary canalization. All bundle CVC. Can I ask you one thing? If you actually put CVC in operating theater versus A&E or versus intensive care unit, which has got the highest incident of infection? ICU, can you raise your hand? Less. I see, okay. Okay. What about A&E? Less or more? More. Operating theater? Less. Okay, I'll show you paper. Highest incidence in operating theater. Why? Okay, then let's actually talk about the logic, which is very important for practical purposes. Why? Because A&E, the patients are very ill, and they always a break in the sepsis technique. The turnover of staff is quite high in all bits and pieces, okay? ICU, most of the staff are actually trained, so you see less. Operating theater, interesting, isn't it? Most of the time done by the anesthetists. But because they do not actually follow the asepsis technique, what I'm talking, they actually think because they're thinking in theater, they can get away with murder, okay? They can do whatever they want. They can spit on it, and the person will not get any infection because it's operating theater. And second thing, because it's green towel, okay? So everything is sterile, you understand? All the green towel has never been washed. So this psyche, you know, is not correct. I can tell you, you can put central venous catheter in car park. And if you follow this simple procedure, your patient will not get infection. Okay? So the environment is not so important. So fumigations, you know, cleaning up this sort of thing, damn thing, stop all this sort of thing. Just go to these basics and you'll get huge result. Okay, so disinfectant, I think we know that it's isopropyl alcohol with chlorhexidine. Okay, we talked about it yesterday. You need sterile permanent dressing so you can see things, what's actually happening, so you don't fiddle with the dressing. And you have to record the time. Why? Because you simply cannot implement bundle unless you have this data on time. Okay, otherwise how are you going to see? The compliance is quite important. Okay, review, inspect on daily basis, aseptic technique, yeah, and disinfect the hub with alcohol or chlorhexidine, doesn't matter what's available, you know what I mean, at least for 15 seconds. I personally prefer alcohol, okay? It's fine, but sometimes you got alcohol, chlorine, doesn't matter at all, you know, that's why you disinfect it. So it's called scrub the hub, 15 seconds minimum. Sterile transparent dressing for 7 days, and sooner if it's compromised, and gauze dressing 48 hours. And then change the administration set for 96 hours, and then in my book, I list all the exact recommendation for blood, for TPN, when you change it. Okay, so I'm not going to go through that. So this is the peripheral catheter. Now, question, this is new evidence. Do you think that the chances of infection is higher with CVC versus peripheral? So raise your hand, those who think is equal. You think is equal. Less, peripheral less, CVC high, raise your hand. Okay, 1, 2, 3, 4, 5. Actually, it's more than new evidence. Cochrane's done the review on that. Peripheral is actually much more dangerous than a central venous catheter. Why? Because of the training. I actually come over, I'm not trained, and I actually put the whole thing in by the other JHO, okay? So it is no either equal or possibly more. So CVC, remember, peripheral is actually much more dangerous. I'm going to show you data from my own hospital. So don't underestimate. If I have to put my target, because the clinicians are trained, but I will put my target, I will put on peripheral as well. Okay, so don't ignore that. It's equal or possibly more, okay? So that's the new data. Okay, so as I told you, Dr. Shastri shown this slide yesterday. The only point I want to say that if you look at 60% of them, they're actually coming from this source. So this is the area you target. And 12% around here and 1% from there. So blood transmissions are pretty rare. Okay, when do you change your catheter? CDC guideline 96 hours. Nonsense, okay? Cochrane has done the review. Now I'm going to make a statement. All indwelling devices, so don't ask me which one. The internationally agreement now, you keep it as long as possible as they're functioning and not infecting, blah, blah, whatever it is. So don't change it regularly. And this is a Cochrane review, which they've done it, highlighting that if you just do not change the catheter, only if it's clinically indicated, in 5 years' time, the NHS will save £40 million, just not following the 96-hour CDC guideline. Okay, so don't do that. Just don't change it. Idea is don't insert it, remove it as soon as possible, and that's the whole message. So central venous catheter, look, this is, I'm not going to repeat myself, the same thing, you know what I mean. Now, I want to just make one subclavian preferred method. And in my hospital, I could not do it. Remember, subclavian is preferred versus interjugular, but your clinician may not be trained into interjugular. Okay, my clinician is not trained. For some reason, in Northern Ireland, Belfast, they're all trained to interjugular. And it has made no difference. I'm showing you data in my hospital, but now it's running for 6-7 years. Okay, so just make sure that your clinician that trained. Now, somebody's trained on interjugular, and you want to change to subclavian. He's going to muck up the whole thing completely, and there'll be more infection rate. So just make sure. So these are all the practical points I'm telling you. Record time, semipermeable dressing. Now, this is interesting, okay? We now have data that if you put the semipermeable chlorhexidine impregnated sponge, have you seen it? Okay, so it seems to me that this actually works. And there are now chlorhexidine dressing available as well, okay? Inspect every day, aseptic technique, hand hygiene, access port, transparent dressing. So basically, you can see it, and you can change it, yeah? This is, those who have not seen the sponge, that's what it is. So this actually goes around it. And basically, it's chlorhexidine impregnated sponge. The whole idea is, remember I was talking to you about it, so when you're putting your dirty hand in bits and pieces, you know, the things are not going inside. Remember I've shown this video? If you keep on contaminating, you know, then they are actually sucking it out and migrating the whole thing. And this basically paper published on beautiful paper written in JAMA. Can you see? This is very interesting. The rate was so low already, 1.4. Okay, I wish, you know, we have it. 1.4, reduced to 0.6. So 50% reduction even on the area, right, when they were doing it. So this recommendation is actually based on this one particular paper, which is really, really good quality. Very rarely I come across really good quality, which make me think, great, you know what I mean, I've read a good paper. Because the amount of rubbish published in the medical literature is just phenomenal, okay? Now, this is another one. People come over and keep on actually selling all these connectors. They are dangerous, some of them, okay? So you have to actually review the literature, and I don't want to go into detail, but there are pumps and there are bits and pieces, and they are really, really complicated. So when you're selecting it, just make sure that you are selecting the right one. They are actually there to prevent the needle-stick injury. It has nothing to do with infection. So these connectors. So 2 things. If you're actually putting CVC line, try to minimize the number of port. If 1 port will do, don't go for 2. 2 port will do, don't go for 3. But people, you know, like, you know, fancy 3, 4, 5 port, you know what I mean, all singing, all dancing. Then on top of that, you put all these connectors on top of it. And some of them, they're really dangerous. I don't want to name they are there. You come over and we could load them information. Just show, but there is actually increase in bacteremia if you start using the wrong one, okay? Do you need it? I'm not sure, okay? Because it's needle sting prevention, okay? Not so just make sure that you must diligently review the literature, which has to be IPC team, okay, who knows how to read the paper in the first place. Okay, so I'm showing you a video of the IV devices. So urinary catheter, again, is exactly the same thing. A couple of things which have changed now because of evidence. So avoid unnecessary catheterization, choose catheter of private size, sterile, closed system, important. Insert catheter using insert. Now, cleaning of meter, no need to use any antiseptic at all, don't waste time. Very good quality randomized control trial has proven that if you clean with normal saline, it's fine. no antiseptic necessary at all for insertion, also for the maintenance as well. So this is now worldwide. We are not using anymore. Everything is in bin now. No more antiseptic. Why? Because the thing is that, when the urethra is all contaminated, the whole idea you want to clean it. So once you thoroughly clean it, you get about 3 to 4 log reduction. If you use antiseptic, 1 more log reduction. If you use antiseptic, because of the organic matter, they're all neutralized, yeah? But with cleaning, can you see? You have this sense of insecurity. God, I'm not using antiseptic. I have to really thoroughly clean it. So remember, 3 things which are important in environment or all these sort of things. Cleaning, cleaning, and cleaning. That's it. Then you use whatever you want. You want antiseptic, you want disinfectant, you do whatever, because you receive 3 to 4 log anyway. So remember, it's cleaning, cleaning, cleaning. And that's all. Okay, so date time, okay, review date, use your aseptic technique, don't break the closed system, use separate container, jug, which is the problem, leg bag, okay, and decontaminate document, okay? So these are all the bundles. So this is again from the new slide, which I revised in my book, so these are the 3 bits. You just have to concentrate. VAP, 5 things, bed rest elevation, head 30 to 45 minutes. Now, how the hell do you know? We were in Africa. How the hell do you know it's about 35 to 40? How do you know? Well, in my hospital, we got a bed which will actually tell you how much you elevate. There's a gauge. But most of the hospitals in the country, right, worldwide, they don't have. So what do you do?
You put a line on the floor, line on the wall.
Pardon?
You put a line on the wall.
Excellent, yes. So this is very good innovation. What else you would do? I normally put a rope. Okay? So if you actually tie a rope, in the bed here, and the elevation, when you lift it, it's 45. So nurse cannot lift more than that because it's 45. It is less, it could be 30. Okay? So you just put a rope. So I just went over in Liberia and bought a rope, and I said, this is 45, okay, the angle. Compass was there, angle 45, and that was it, and end of the story. So they know that they cannot pull more than 45. And you cannot actually do this in every patient. Yeah? Why? Because some patient with spinal injury and things like that. So the clinician have to decide. We can't decide. The clinical people who are actually there who can decide that this bed elevation required or not. Okay, so that's the first thing. So there are some very simple solutions, you know what I mean, which you have to come across in your own area. Because these beds are really expensive. I'm telling you, this 45-degree beds, we have it, they are really, really expensive, and you don't need it, you know what I mean. Sedation, vacation, daily interruption, sedation, assess the weaning of intubation, oral care. Let me give you some example and evidence what we have at the moment. Okay. You have to actually clean the teeth. Why? Because they'll be dirty, okay? So we clean the tooth twice a day. But also, it can cause staining if you put chlorhexidine on top of that, so that's one reason. But actually, when you're doing it, which is not in the book, which I've written in that you have to actually clean the lips as well. So people nurses, you know what happened? Just go and observe. They just brush it and that's all. No. Brush it and just make sure the lips and these things are also clean as well, please. Because what happened? You actually clean the teeth, yeah? But can see all the gunge and muck is lying there, so we normally actually clean it and put a Vaseline around it, to just make sure it's a total oral care, including lips, which is missed all the time, which is not there in the guideline, but this is what we do, okay? Our VAP, what is our VAP? We rarely see VAP. It's completely gone. We may see 1 or 2 a year, okay? We don't see VAP, okay? It's completely gone. And there are certain other interventions we did, okay? So if you don't do the VAP, you can do it. Okay, you have to actually brush teeth twice, and then you have to use chlorhexidine. What evidence we have? The evidence is not really clear-cut. We do not have good randomized controlled trial. It does actually show you, it reduces the bioload, yeah? Not a rocket science, we know that, if you are going to clean the damn thing, we see the number down. It reduces the number of bacteria as well. Does it really VAP? We are not really sure. But anyway, This is now part of the whole thing, oral care. And the whole idea is that they don't keep on aspirating all these sort of things when people are putting fingers in their mouth and things like that. Now, toothpaste, chlorhexidine inactivated by the toothpaste. Yeah, you know that? So you have to leave at least 2-hour gap beyond it. So remember, toothpaste, cleaning twice a day, 12 hourly, chlorhexidine 4 times a day. But sometime I've seen it, okay? Brushing the teeth and putting the chlorhexidine. Chlorhexidine instantly inactivated. So can you see what I'm trying to say? People are actually doing things, but they don't know how to do it correctly. So what's the point of doing? And then you know what? You actually told me actually that to implement this sort of things and it's not working. Okay. Then you actually go and see the practice. They're not doing it correctly. What's the point actually buying a cheap product but it's not effective? What's the point of actually doing the practices which are not effective because they're not done properly? Okay. So think in these terms. Okay. I've done this, always not win. I give you an example of the CVC line, isn't it? Why? It's the attitude. Subglottic secretion, very important. This is where the pooling actually occurs. And then the ET cuff pressure has to be made in between 20 to 30. How do you do it? This is the endotracheal inflation tube, and this is the cuff around here. You inflate it, okay? Now, you have to actually do it. How often you have to do it? 6 hourly. In our IC, we do it every 4 hourly. It's too much, I think it's overkill, but 6 hourly will be fine. Why you do 6 hourly? I need a break. Why 6 hourly? And not 12 hours. Huh? Say something. I mean, look, over here, this is not exam. Just use your common sense. Huh? Pardon? Not really. Reason, yes, the answer is right, but can you see subglottic drainage? You are doing on regular basis anyway, so they should not have collection of secretion. This is actually because the patient actually come over when they are actually very ill, they got edema. So what actually happens if you put 20 mil pressure within 6 hours when they're coming over and when they're doing the proper bits and pieces, right? The pressure can go up and down. So even a very small secretion can trickle down. Especially remember in burns patient, yeah? They come in, they are swollen completely, AT tube. So you have to actually make a judgment. The whole idea is to keep this pressure. Okay, as I told, we do it 4 hourly. I think it's overkill, but it's good. That you keep on suctioning it, okay, which varies a lot depending on the type of patient, which you are right, yeah? But also just to make sure it doesn't trickle. Okay, so this is again common sense. So there you are, cuff pressure. Okay, so keep on, get rid of this one as soon as possible, okay, suctioning. And then cuff pressure. If you don't do it, and if you just keep on sucking it, your patient will get pneumonia. Second thing, in our hospital, you know the tubing, the ventilator tubing? We have it, and we have this electric wire going underneath it. So you come over, you will not see a single drop of liquid or moisture in our ICU at all. Completely dry system. Everything is sterile water for humidification, for nebulizer, okay? And after sterilization, we took over and we sterilize the whole thing, and we put a sterile water. So these are the area of VAPs, suctions, proper this sort of thing. So you do this one, which people do, keep on suctioning it, till the patient actually develop the erosion of the mouth, but don't do this one. Now, what about this one? Do you think nasogastric tube? This is the most awful thing. When you actually come across a patient in ICU, and this actually was yesterday, and the patient got fever, always think of sinusitis. Because the NG tube actually blocks the sinus, and they will develop sinusitis. So most of the ICU patients will have fever because of sinusitis. Just go and do their scan, and you'll find sinusitis. And we don't think about that. So we look at the fever, and then you look at the microbiology, we are growing this, and then you keep on treating it. So this is one of the most dangerous stuff you are using in ICU, NG tube, which is completely ignored. Okay, implementation. How do you implement it? Okay, I'll go for the payment. Okay, so you can go and download this from the IHI website, how to implement it, and there are different ways of doing it. I did not do this one. Okay, so you can do whatever you want, and I'm going to talk to you tomorrow. But okay, So what basically, you have to ask these 3 questions, and then you do this PDA cycle. You can download the IHI website. So the first question they're asking, and these 3 questions are very important. What are you trying to accomplish? So basically, the whole idea is that you want to see reduction, yeah, of CLABSI by 20%, 50% by December 2000. You have to have your aim. Without aim, you're not going to do anything at all. So you have to have your aim. And this is, how many people who have read Lewis Carroll, Alice in the Wonderland? Every time when I read this book, I actually find something different, okay? This is just a wonderful book. The person was born in Northern Ireland. I visited his house. It's just wonderful. It's written for children, but contains huge amount of philosophy. Now, this is the thing. So this is Lewis, those who doesn't know that, the cat is actually sitting over there, and the Alice is actually going. And he said, which road do I take? So Alice is asking, Alice is now lost in the wood, and he's asking, what road I would take? And the cat asked a very simple question, where do you want to go? And the Alice basically, I don't know. So she actually said, then the cat said, it does not really matter. If you don't know where you are going, any road will do. So the question I think around here, what I'm saying, when I actually sit for the interview panel, even for a consultant for all these sort of things, I ask only one question to everyone. How you see yourself in 5 years? And there's a total silence, okay? The dead silence as I was speaking to them in a Chinese language, okay? So I think you want to see where you want to go in your career, okay? I ask my question, where you want to go? My son is, where you want to go? What do you want to do in 5 years' time? Where you want to go? You have to prepare now, you know what I mean, what you want to do. Otherwise, you will not go there, what you want to do. So I think this is quite important. So you have to set. Second question, I think, how do I know that change has made improvement? So you have to do the process surveillance, and you have to do the outcome surveillance, okay? So you need this data. So the whole idea is that you're complying with the bundle. Outcome survey is important to actually convince the clinician, yeah? To convince the clinician, look, these interventions you are doing is actually achieving the reduction. However, if we actually fine-tune these ones, which are not done in terms of compliance, then we can achieve a little bit more. Second thing, I think these bundles and everything is very simple. You have to tailor-made to your own hospital in terms of what priority you have. And I'm going to come this afternoon about the priority section. It's different. Mine is different, yours is different, yours is different. So although you're all from India and the same hospital, but you have different issues in IPC, okay? So you have to work it out what you want. So first is what you want to accomplish, set the targets, set the direction, monitor it, and modify it according to your own needs. And then you do this plan, it's basically plan to act. So you can download all these slides from this sort of thing. Now, this is the important slide. Remember, all improvement will require change, but not all change will not result in improvement. Why? It's exactly that telling people that to do these sort of things without telling them properly or educating them, right, or certifying them, that are they really competent to do it? Do they understand? It's just like you simply cannot learn driving by showing YouTube video. Yeah, can you do it? No. So in my hospital, people actually train, I bring them, and as I told, remember I did the PPA demonstration, but I do demonstration of virtually everything. How to insert a catheter, right? How you open your sterile pack, how you put CVC line, all bits and pieces. And people from Russia, Croatia, Malta, they came over, and their infection is plummeted, after that. Because I thought you have to really teach them, you have to show them, what it is. Not by telling them, what I mean. How you clean your skin. I'm telling you, people don't know how to clean the skin, even clinician. We've been there for so many years. So you think it's not, that's why if you don't succeed, it's just because the way you are doing it. And human beings make mistakes because the system and the process are really poorly designed, and this is an issue. So the question is, if I'm not inserting central line in a proper way, is it me or is it the system? Okay, I always blame the system, 95%, 95%, because we do a lot of work on system analysis, and we salami-slice the whole thing, and we give them the recommendation, to see where things goes wrong. So So what actually happened when we actually identify the performance deficit? And that basically means why things are not done. So first, I think performance deficit, what we describe in psychology as type 1 error. And these type of error are classified as omission, that people don't want to do. Why? Because they don't have knowledge. Yeah? They're not competent to do it. You did not tell them. Yeah? They do not have an adequate education and training. Or they have education and training, but what quality of education and training you have? Okay? By telling them to do that sort of thing and not demonstrating it. Did you see yesterday we did a, okay? I'm not sure you learned anything, but I think some people have actually picked a few ideas. So it just, when you demonstrate and people will remember it, that, yeah, okay, this is rational behind it, you know what I mean? So when you do this training, so normally what happened, what we call, you know, which I hate, death by PowerPoint. Keep on pressing PowerPoint after PowerPoint after PowerPoint. This is not, you have to have what we call learning. So visual images, you see the demonstration. That's what I'm doing, blended learning, okay, psychologically. I'm showing you certain things. I'm showing you some videos so you can have a little bit of break, okay? And I'm actually talking to you, and you're answering the questions, okay? So there are 4 parts of blending learning. Lack of availability supply, you know what I mean? There's no point actually bashing the observation is low when there's no alcohol hand available. Why? Because nurse is not going to, it is not their responsibility to top up the whole thing, isn't it? They run out of what are you going to do? So this is what we call type 1 error, lack of mission. Type 2 error. Somebody was asking me yesterday, this is act of commission. These are the people who simply don't want to do anything, you know what I mean? Bugger off, basically, you know, they are saying. I'm in charge of the cardiothoracic unit or orthopedic, and this is the way I'm going to do, and that's it, really. So these are what we call act of commission. So there's lack of commitment and consideration of the other, not looking at the evidence. And you will find lots of the clinicians are like that. Those are really, really difficult to deal with, okay? And this actually, you can't do it on your own unless you need a senior management backup. Those are complex. And you need chief executive to basically kick their backside to do something, okay? So this is an issue I think you see. So the third part of deficit, so remember the first one, yeah? So remember when you're actually suffering from this sort of thing, you just make sure which category does it fall in terms of performance deficit. Third one is actually type 3 error, which is very common, so common in infection control, okay? So basically you are applying the wrong solution. You know the problem, but you are applying the solution to the right problem with the wrong thing. So say, for example, if you've actually with all good faith, you have picked up this connector, but you do not have enough information to read the paper, you picked the wrong connector. Or you picked a hand-in gel, which is completely and totally ineffective without looking at the evidence. So that's us. So sometimes you say, I'm doing all bits and pieces, and nothing is actually happening. It is you who are the problem. Because you do not have information. You either misinterpret information, yeah? And remember, I'm talking of hand gel and what is the right one and quantity and bits and pieces and steps. So you are actually doing it, but you're not doing it right. And these are the reasons. And sometimes the information is misleading. And there's a whole session, I think there's a webinar, which I want you to, DDAPT is going to do it. The amount of rubbish published in infection control and myths and things like that. And we are now actually demystifying all these other things because this is derailing the process completely. So try to actually work it out. These are the 3 areas. So try to classify them into which category they are actually fitting in, yeah? Because then you know the solution. Otherwise, you will not know the solution, okay? So we'll come to talk about risk assessment where this concept, what I'm trying to do, will be clarified a little bit more. Managing change, I think it is not it is very difficult. And this is my favorite philosopher, Jean-Paul Sartre. In football or in cricket, okay, everything is complicated by presence of opposite team. So what actually happened, that you're actually trying to tell the clinician to do certain things, and they will say, no, okay. Or show me the evidence. Okay, you're talking complete nonsense, you know what I mean? Don't come to me. So it is, infection control is not simple. So when you say something, or you actually come across the chief executive, or the medical director, or the nursing director, you know what I mean? It could be anybody, you know what I mean? Now, important thing is this. As a human being, yeah, as a human being, I don't want to be criticized, honestly. I want to be praised, okay? That's the human nature. That's what the God has made us. So, if you are now telling me, as a clinician, that look, you know what? You have been practicing this for the last 20 years, 30 years, but actually, you know, you are wrong. Now, the question is, this is the habit he has developed for the last 30 years, okay? How is going to change it overnight by you telling me to do different things? I think it's very important. It's not hard to learn more. They will learn, yeah? But it is, what is hard is unlearn when you discover you are wrong. Because these are the people who have got ego of a universe. Okay, they are the big people, okay, big egos, you know, and they will not admit their mistakes. So this is a big issue, how you deal with that kind of thing. So we do this behavioral seminar for 3 days, and we tackle all these issues and how you crack those egos as well. Okay, so but we don't have time to do it. So these are the practical issues. These are human issues. These are human factor. So let me go to the BART system, because people don't want to criticize. So let's see what BART symptom had to say. So you are aware of BART symptoms, yeah? Okay, most of it. So here, before you criticize someone, you should walk a mile in their shoe, okay? So put them in their shoe. So what will happen? That way you are a mile away and have their shoes. Okay? So let's actually talk now about measuring outcome. This is Lord Kelvin. You have to actually measure it, because if you don't know where you're starting, how do you know where you're going to go down? So you have to have and this is the reason you've done surveillance, yeah? And audit and bits and pieces. These are actually quite important, because you know what the baseline is. It is actually basically setting the direction of your travel, which travel you want to go, yeah? Now, I think there's always difference between the intention, the mismatch between the intention and the action. You see, people do what you inspect, not necessarily what you expect. So I tell my children that he should go over and read this sort of thing. He closed the door, what he's doing. If I open the door and watch him, his behavior will change, okay? So this is called the Hawthorne Effect. You know about Hawthorne Effect? Yeah? Hawthorne Effect, how many people? You have to know about Hawthorne Effect and infection control. So that means what actually happened, this Hawthorne Effect will happen in Illinois. And this tube light company were making it. They actually came over and said, you know what? If you increase the light, yeah, in your factory, the production will actually increase. So what happened? They put a light, and the production increased. And then when the light was dimmed down, the production was also increased. So what actually happened? Hawthorne Effect is basically that when you are observing something, their behavior will change. This is what happened in hand hygiene, which we call Hawthorne Effect. That when you observe something, their behavior will change. So, as I've told you, when you inspect, then it's different than what you expect. So you expect your surgeon to do A, B, C, D, but when you inspect, actually it's not done. And classical example, tick box mentality. 100% everybody washing their hand, but you go and inspect that basically they are just tick boxing the whole thing. Have you seen the line? Yeah. Yes, you know what I mean. But the line, and then suddenly 3 days later, you see the 2 liter of pus is pouring out. So nobody washed it, yeah? If they washed it, they know. I've seen it as well, you know what I mean? Look, this pus is pouring out. I see 100% compliance. So you are just making just tick boxes, because this pus is not actually develop overnight, you know what I mean? So I think outcome surveillance is quite important, but the process surveillance is very, very important in terms of monitoring to see what people are doing, taking the element of the bundle. So you take the element of the bundle, you monitor it. Now the question is, how do you do it? Okay. So you can download this particular form from the internet website, and you put into the grid, and you can change this information what you want, depending on the catheter, for example, and then you get this compliance. Now I want to show you some examples of the 2006 when we implemented. The first priority was to actually get the CVC bundle. So can you see, before intervention, hand hygiene, people were doing it. I said, okay, how you were doing it? Variable. Sometimes they were using chlorhexidine, iodine, sometimes they were washing hands, sometimes. Basically, the idea was they haven't got a faintest clue what the hell they were doing. So we say, look, is antiseptic hand wash, you do it for 1 minute, okay? If you tell them 1 minute, they'll do it for 30 seconds. If it's 30 seconds, they'll do half, okay? So it's 1 minute, okay? So second question is, people were using alcohol, povidone, iodine, chlorhexidine. It was just duration. I said, okay, alcohol, how long do you apply? Oh, I just leave it a few minutes, but I said, no, just tell me, could not get any answer. 6 anesthetics, 7 different answers, okay? Okay, and they were all multi-use. In the big bottle were sitting there, so basically they were all contaminated. So when they were using it, they were all contaminated solution. They were not in single sachet, okay? Then maximum barrier precaution, very variable. Ideally, you should actually have a full length gone, but half will do as well. And Americans actually are very big into the caps. We don't use caps, and we are fine, okay? And as I've told you, daily monitoring, very, very poor recording, very poor recording. Subclavian versus internal jugular. Remember, I've told you, our clinicians who were not trained to put subclavian, they were really very good at internal jugular. We did not actually find much difference at all, okay? So just be sure you implemented, this should be here. And then the other thing what we did was, can you see these are all the bundle bit. The additional bit which I did, right? Remember we're talking about the 4 or 5 additional bit we have to actually do it to cement the whole thing up. That we have got one hospital, we've got 3 different packs. Now, would you imagine it took me 6 months to agree how many swabs they need. So one anesthetist was happy with 4 swabs, and the other was 16. And it took me 6 months to agree that you will have only 1 pack, okay? You tell me how many swabs. No, I don't care. You put 16, you put 20, or you put 2, I don't mind. So eventually we agreed to 8 swabs, you know what I mean? But it took me 6 months and chief executive intervention because one clinician will not actually abide by the whole thing. So sometimes these are difficult. So you have single pack, yeah? That means if you're putting a central line, you will have pack. You know what it's inside. Now, if there are 3 people that are using different pack with 3 different material, and I'm actually coming as a registrar, give me a pack, and I say, oh, God, I don't have this, and I don't have that. And then they run over and get the things that, and this is where the break actually happens, okay? So we agreed. And then the training was formal training, we did that. That training was actually done on mannequin, okay? Because I don't believe in PowerPoint, remember? So I actually bought the mannequin, I actually told them how to clean it, how you put a line in, how you do the bits and pieces. So they trained the whole thing. So they did it, and I observed it and said, look over here, can you see over here there was a break in the aseptic technique, this is not right, and this. So anyway, so this training was actually done on the mannequin. So we changed to epithetic, we changed to Chloraprep, I'll show you in a minute, and it was single use, and the drapes were all new, and then we have sort of single monitoring form. Now, where do you do monitoring? Should we actually do in the nursing notes? Should we do in the medical notes? Should we write it? Where do you do? Okay, confusion. So we got medical legal agreement, right? Because if we are actually go and somebody sues that I've been to court over 3-4 times because my clinician did not actually do the central line properly, okay? The court look document, yeah? If things are not documented, thing does not exist, you have not done it, that's it, okay? Ignorance, remember, in the court of judgment is no defense. And we were sued, and I tell you a few incidents where I've been to courts where we lost case on lots of things, okay? And there are very interesting cases. Anyway, so a single pack, okay, one for each hospital, because other hospital will simply will not agree. You know what? We are actually different than the other hospital. So anyway, okay, I said, fine, okay, you actually use your pack and you use your own pack. So 2 hospitals, 2 packs. But the rest of them, they were all fine. And then they've got a structured training program with blended training. Okay, so this is Chloraprep. I don't know whether you've seen it or not, but basically what it contains 2% chlorhexidine. And when you press it, this is the gauze, it releases over there. And then there is a method how you do it. So you can't, there's a method. I taught them how to actually do it. You do it like that, and there was a very precise method of 2 minutes, and they followed it, okay? Now, this was our central line infection. We were the first hospital in the UK to implement the bundle, not only in the ICU, but throughout the whole hospital, both of them. Okay? Now the paper coming over, we are doing the community, from Geneva, but we have done it, you know what I mean? Now, if you get a central line infection in my hospital, it's a big incident. It's gone completely. Can you see? There was a period. So can you see it went through this bumpy ride, okay? And then it stays around there, and then it stays around there. So basically now we get about 2 or 3 a year, a whole year. It's virtually gone. VAP, we rarely see them, 2 or 3, occasionally we see them, but it's all gone, okay? So remember, this is no fumigation, no overshoes, no cleaning of detergent, you understand? Can you see what I'm trying to say? This is what we did. Because those are the things that stopped 30 years ago when I was a consultant. This has started in the last 10 years of mine before I was going out. And the same thing, I think, now this is what happened in my hospital. A person with peripheral line, somebody completely forgot, okay? And this is patient developed infection. So just to actually digress and tell you the interesting story. So one patient, very interesting story. One patient, first day, okay, of my being a consultant, and I got a phone call saying the patient is going to sue us. Why? Because the peripheral line was actually left inside. So she went to the GP, and the line was removed. No infection, no thrombophlebitis, nothing. So she's now suing for 350 pounds. Okay, that was a lot of money, about 30 years ago. So I got a phone call. I told our medical legal team, okay, that look, there's no point me actually going to court and defending it, okay? Just give her 350 quid, okay? Forget it, because time is very precious. So we gave. What happened? The patient came over. We have got 4-story hospital. The patient actually came in the morning and the evening, telling every patient that just make sure if you got cannula, you wrap it up, go home, because the hospital is giving 350 pounds. So she went from floor 1, 1 south, 4 south, 4 north, each other. So we had to employ 8 nurses, would you imagine, while she was there, because we were telling her. So we have a patient wrapping their hand, going out, and we were checking that the cannula is out, okay? Because we did not have any program, you know what I mean? So it's an interesting thing. So this is actually happened. Now, so then actually this prompted me, remember, first I tackled the central line, okay? Then pre-intervention, IV cannula, bacteremia, post-intervention, arrival of new doctor, not trained, okay? So then we trained them, and you can see that 14 bacteremia down to 2 bacteremia from the peripheral line as well. So you can see what I did, simple thing, teaching all the things what I'm talking to you. So you can do it for the peripheral as well, because this was actually good. And this is the VIPIS score, this is the form we normally keep. So you can see the MRSA bacteremia went from 16 to 1. And MSSA, we see 50% reduction. Now, the compliance. Do you do compliance with everything or all of it, So do you actually monitor, say for example, in bundle, right? You got 5 elements. Do you apply all 5 elements to all of them? We could not achieve it. Okay? Difficult. Okay? So the question you are going to ask me, what do you do? So I'm going to give you answer. So the way the compliance is maintained, forget about this. So this patient did not actually get element 2. Okay? So compliance is 0. This patient did not get anything at all. This did not. The overall compliance to all elements of the bundle were only 40%. Now, so I was looking at literature to actually find out, to see, does it really make difference? And second thing, which element is actually more important? Yeah? Because at WHO, we ask this question again and again. Out of 5 movements, if I have to do only one, which is more important? Right? And we say all of them are important. Okay? So this is a paper published from America, 250 hospitals. Okay? Only 30% of those with multi-model implementation reported full compliance, only 30%. They missed only 1 or 2nd element, yeah? Now this is interesting. Unfortunately, they did not actually do the impact of hand in their analysis, okay, which is shame. So taking each central line element individually, there was no statistical significance with CLABSI rate. However, all element leads towards reduction, except chlorhexidine. So you take all these 5 elements, chlorhexidine actually increases the rate. Hand hygiene, they did not analyze it. So what went with chlorhexidine? The information we did not actually get was, the paper did not provide any information, what concentration they were using, what technique they were using, what was the contact time, what they using sterile solution and antiseptic solution, because this is the most crucial. Remember I showed you the video? Yeah? If you are actually using contaminating antiseptic, which is very common, use the multi-use bottle everywhere, it's a disaster. So stop fumigation. The money which you are going to save to disinfect your floor with Dettol and all things, get the single-use thing, because this is the major intervention. When our infection rate came down, is because of that, because the multi-use bottle, we grew bacteria from virtually everything. Okay? This paper did not actually say that. However, the meta-analysis we have done, and very good quality randomized control trial, shows very, very clearly that alcoholic chlorhexidine is the best antiseptic. So why this? So they did not actually do that. So I have no doubt that this paper, the contamination with antiseptic was a major issue. Okay? Now, yeast. I just want to tell you something which is just going to digress. You were actually saying yesterday, a lot of yeast. Remember, there are actually outbreak of yeast infection, which we have reported about 25 years ago. If you look at my paper, we published it in dialysis unit. Cross-infection, right, is actually very common with yeast in the intensive care unit, which is under-recognized and under-reported. So if you go back and take all the sample and analyze it in your reference laboratory, you'll actually see that there may be an issue with that. If ever you're getting some yeast, you've got a problem. Second thing you have to understand that you have to use alcoholic hand rub to kill the yeast as well. So hand hygiene is important as well. Okay, so chlorhexidine is more effective. Yeah, so chlorhexidine is effective against gram-positive organism, but not against gram-negative. So this is the chlorhexidine they were using in the ICU, which I think you don't need it, okay, for normal hand washing. Antiseptic procedure, yes, you have to do it. So I think, okay, so the bottom line of this particular paper, the result do imply that if the average ICU complies with at least one component of the bundle, at least one, they actually found that you can reduce your CLABSI rate by 38%. Wonderful, isn't it? So what I'm saying is start somewhere, okay? Don't get disheartened. If I show you my implementation, how I did it, it's a very interesting thing because I don't have time to do it. I actually came across the brick wall, okay? But I keep on fighting all the time. So this is very important. Don't get disheartened. Just start somewhere, keep on edging it, you know what I mean, slowly and gradually. Now, the question is, this is a big debate. Does really bundle reduce infection? Now, in America, you know, there's a pay for performance. That means if you go to hospital, yeah, and you get infection, the insurer will not pay you. You get catheter infection, I will not pay you. If you get surgical infection, I will not pay you. So this is the bit. So what happened, the only way to do is to actually massage the data, okay? And this is what they do. So I think there's a lot of debate going on. I'm going to show you another slide in a minute. That the pressure to look good motivate hospital to underreport CLABSI rate, overreport compliance of CS bundles, just make us a bit much serious. And this is all because of pressure. So remember the data coming from the America, sometimes they are skewed. Now, if you don't believe me, I actually come across this paper, which is very interesting. Okay, this is a paper all published. This is the now the American physicians are all up in the arm. That when they are comparing, they're not being paid kind of thing, it's not their fault. So what they are doing, so can you see, they are now actually putting, so US data. So first, central line data cannot compare between the hospital. Yes. Why? Because remember, they are actually, it's a CLABSI, yeah, for which you are not paid. But if you get bacteremia from the peripheral line, then you are okay. So what would you do? Stop using CLABSI. Yeah, put more central line, put more peripheral line. And this is what they did. So bacterium rate actually went up because now the penetrants are completely messed up. They're putting less central line and 2 or 3 peripheral line and keep on changing it. And the bacteremia is more now. Okay? So can you see change in practice when you put the pressure? And pay for performance have not shown to make any difference on the reduction of HAI in America, okay? So the question I think around here is sustainability is a big thing. Now, if you want to change habit, you know what the psychology of habit is? You see, but like New Year, remember I've told New Year, we actually go for jogging, things like that. So the science, the behavior science for the habit, if you want to inculcate habit in you, you have to do the same thing 53 times every day. Then you automatically you wake up and you know what you do? Straight go to the bathroom and brush your teeth, okay? You don't have to think about it, okay? Sometimes you may have actually instead of toothpaste, you may have shaving cream, okay? But you do it, okay? Because it's automatic, you don't think about that. So you have to do 53 times every day. So you do 40 times and then on 41 day you miss it, you have to go back to 53. If you do 53 consecutively, that is your habit developed, okay? That's the science behind it. So 53, any interruption, 53 again kind of thing. And then you're embedded. The question, I think, sustainability, how do you sustain it? You know what I mean? The improvement quality, say 70% organization don't actually survive and change the effort. Remember, when you are improving something, it's not an event. It's a process. And you keep at it, you sustain it, you keep your eyes on the ball all the time. Now, this is just want to show you the hospital. When you come to the hospital, the first thing will hit you. This is the, even the car park ticket have got hand hygiene. Have you washed your hand? Anything like that. So you can see this is the entrance of the hospital. Have you washed your hand? And this is all wards have got this. So you can't miss it, you know what I mean? And then this is the chief executive, you know, who comes over and we've got hand hygiene day. Now this is a group of the patients we have. So we involve patient as well, okay? Now sometimes they challenge the doctor and you did not wash my hand and things like that. You know, sometimes, you know, we have this complaint kind of thing. So it can be very challenging. But patients are very vulnerable. You know, when they want to come over, if I'm a patient of yours, I don't want to upset you, yeah? But I don't want to tell you, please wash your hand kind of thing. Definitely it's not going to happen to India. Why? Because our cultural differences, you know, the power distance according to Hofstede is huge. Our power distance, you know, is very low, okay? Patients are actually paying for the health service, so they need the best of it, okay? In our part of the world, if we survive, it's the doctor who has done the wonderful work. If we die, it's God's will. Over there, anything right or wrong, it's all doctor's fault, end of the story, no God, okay? So we are actually have big litigation. Our health budget, you know what, for litigation in UK? So we've got 108 billion pound, 118 billion for the health service budget. 2 billion is only for the litigation, and this year it will be 3 billion. So litigation is a big issue, you know what I mean? So I think I will just say, this is Mahatma Gandhi quotation, okay? So it's a first, they will ignore you. Then they laugh at you and they fight with you and then you win. So this Mahatma Gandhi have said this sort of thing. So basically saying keep on fighting for the good cause which you are actually doing. And the last slide, that from Dalai Lama, he said, if you actually think that you are too smart to make a difference, try to sleep in with a mosquito. Okay? So keep at it, slowly and gradually. I've given you something that where I have done all these sort of things, it was not really easy, even in my part of the world. You have got very different challenges. Don't lose hope. Even if you reduce your infection by 1%, look at your institution with 2,000 plus beds, you know, 1%. Look at the number of patients you are going to benefit. So even if you reduce 5%, 2%, 3%, fine. Keep edging at it slowly and gradually, okay? So this concludes my presentation, okay? So thank you.